This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast. And welcome back to the Alert Medic 1 podcast. Tonight you've got myself, Moose, Ken, and our guest, Dr. James Brady, once again back on the show. This is your fourth or fifth time, yeah. Fourth or fifth time. Becoming quite the regular. And tonight, our topic is going to be serotonin syndrome. Not something a whole lot of people talk about, especially in EMS. And we've got Ken to talk about a personal experience and then see where it goes from there, with Doc talking about what he knows about it, his experiences with it, and we'll see where it goes. So, Ken, without further ado, you want to take it away?
Sure. Okay, so I'll tell you a sad story that happened to me a few years back, and then we can kind of dive into what it is, what serotonin syndrome is. But this was back in 2016. I was a strapping young paramedic on a big city, inner city, big fighting ambulance. And I was minding my own business, doing my normal routine, when all of a sudden I started feeling very dizzy. I felt like my heart was racing, and I knew something was wrong. So to back up kind of where this is coming from, about 6 months earlier, I had been diagnosed with bipolar disorder, and I had been put on a cocktail of medications that was forever changing because we couldn't get it right. I had multiple instances of tachycardia and tachypnea at home and in my daily life over those 6 months, but I just kind of ignored it. I mean, obviously I'm a paramedic. I know that's not normal, but as human beings, we have a tendency to minimize our own signs and symptoms, and I should have picked that up as a major red flag, but I just ignored it. So fast forward back to April of 2016, I knew my heart rate was up. I wasn't feeling right. I was tachypnic. I was tachycardic. I was dizzy, like I said. I walked over to the ambulance and I put myself on the heart monitor. And my heart rate was anywhere from 160 to 180. And at that point, I knew I was in trouble. I can't remember who I was working with that day, but I know it was not my normal partner, because if it was, I would have let him know that something was wrong and that I needed to get looked at. But I was working with the firefighter of the day and I didn't want to make a commotion, so I just kind of checked myself out. So at that point, I put the ambulance out of service. I called my supervisor. I said, hey, something's wrong. And then things start to get real fuzzy real fast. I remember that I was very hyperverbal. I was very hypertensive, tachycardic, tachypnic. A lot of it's kind of a blur. I got into the other ambulance somehow. I don't remember how. I remember them hooking me up to everything. My heart rate had come down somewhat. I remember them talking about adenosine, but not getting it. I remember them not being sure what was wrong with me. And then I remember my supervisor, my old supervisor, showing up in addition to my current supervisor at the time. And that's when they started really drilling me about like my medical history and do you take any medicines and stuff like that. And it started clicking, I think, that it had something to do with all these medication changes that I had been going on. So at the time, I was on 40 of Vyvanse, 5 of olanzapine, and sertraline was 50. They got me to the hospital. Instead of taking me to the hospital they were supposed to take me to, they took me to a major medical center. I was there. It's hard to say how long before. I remember the doctor that came in was one of my favorite at the time. And I just remember his face and his big bald head, like, looking at me. I remember I got Ativan and or Valium. And I was in the ED for hours and hours, but I probably have conscious recall of minutes of it. At some point, my wife showed up, and she told me about this long list of visitors that I got that I remember none of. They admitted me. I was there about 2 days. And then they sent me home and said, don't take your medicine anymore. Call your psychiatrist. So I did. And I haven't taken an antidepressant since then. They managed everything with mood stabilizers and antipsychotics. So, which is good because there were a couple red flags there as they switched me from SSRIs and SNRIs with the periods of tachycardia and tachypnea I was having. Mild exertion, I'd get very winded, get pretty tacky into like the 130s. My respiratory rate would go up into the 30s. If I drank coffee, I'd get sick. Like tachycardic sick, not like, like GI sick. So it was a very interesting experience from both my perspective and the clinical perspective. It was scary, like that could have gone really south if they hadn't identified. Somebody obviously identified what was wrong with me somewhere along the line and loaded me up with benzos, which frankly saved my life. But they could have gone the whole, are you on drugs route, or they could have gone the whole, this is a cardiac issue route, or, who knows what route they could have gone, if they had injected me with more antipsychotics or something like that, that could have been disastrous, I would imagine. If they had, tried to cardiovert me or give me adenosine, that would have not helped. So, it's, I guess in a nutshell, that's my story. It was quite harrowing.
Yeah, like that. Thank you for reliving that. Obviously you said it's very traumatic experience. It's terrifying to not know what's going on and not even be able to recall, hours of being in the emergency department, which is like, I think one of the biggest staples of serotonin syndrome. If you don't mind me asking, were they around the time of the diagnosis, did they had just change your medications around or add medications or just increased?
Yeah, so it's interesting because I actually have here my med rec from my old psychiatrist. And I started seeing him, it looks like, in March, the end of March of 2016. March 31st was my first meeting with him. And my follow-up meeting with him after the serotonin syndrome was on 4/14 of 16. So I had only been with him about 2 weeks. And prior to that, I had been misdiagnosed with depression. And I had gone through, every antidepressant in the book they threw at me, and none of it helped me clinically. And a lot of them induced that tachycardia and tachypnea with mild exertion or like caffeine or anything like that. So they had changed my ADHD meds a couple times. It looks like he had changed that on our initial meeting, and he had added the sertraline and the olanzapine all was new. He also had me on. I was taking Klonopin for my anxiety. I had really bad anxiety and untreated PTSD at the time. But I don't know that was really a factor. I mean, that's kind of like the opposite of everything else. So
Yeah.
I don't think that was it.
Yeah. I mean, because one of the big takeaways is serotonin syndrome typically presents like soon after a medication change or dose increase. Typically, if someone's on a stable regimen of a serotonergic medication, it doesn't typically present. It does not mean that there's not a possibility, but typically within 6 to 24 hours of a medication change, the symptoms can start. And it sounds like you had your symptoms pretty soon after starting the medications with the tachycardia.
Mm-hmm.
And it just kind of came to a head after repeatedly giving yourself the medications until the point where you had the confusion. I don't know if you're agitated or not, like that. Those symptoms that where you don't even recall going into the hospital. Really, you remember seeing a bald-headed doctor and a whole stream of visitors that never even you don't even recall coming in and seeing you. So obviously, it got a lot worse over the 2 weeks that you were taking those medications.
Yeah, and it's interesting you mentioned the agitation. Definitely confused, but I remember feeling the most like, I mean, almost like ecstasy. Like I felt so good. I wasn't agitated or combative. I just thought this entire situation was hilarious, and I was on cloud nine. That's how it felt.
So you had, I guess, the good neurologic symptoms of serotonin syndrome, as opposed to the agitated, trying to throw people and just very angry type of serotonin syndrome, which I think is more textbook of what we were taught of, like that agitation, that restlessness, that inability to sit still kind of symptoms that we typically see with serotonin syndrome.
Yeah, it was definitely it was an interesting experience. It's not something I would wish on anybody for sure, but I think it is important for people to be able to identify that, for paramedics to understand that this is something that is out there, because I think there's like a sentence about it in the textbook for paramedics, but that's about it. And if you don't recognize it and then you don't treat it right, you could make things worse. You could potentially really hurt somebody.
Yeah, so Ken, actually,
yeah,
pulled out my book from paramedic school, which coincidentally, the dates you're giving is almost the exact date I became a paramedic. I think it was the 15th of April of that year.
Oh, wow.
Yeah. It was when I got like all my
So
testing
I was
done.
still in the hospital with this when you were becoming a paramedic.
Yeah, in El Paso. Yeah, I was literally getting my cards from National Registry right around that time. But so like a quick recap before we dive into also like the in-hospital management from the doc. So for all the medics out there, like Ken said, this is probably unrecognized a lot by us. Luckily for him, whether it was the medic that treated him in the back, his supervisors, or someone, it just clicked. Something clicked that they realized this is not a cardiac issue. This is not something else. This is not drugs. This is an anxiety attack. Because Ken, when you were telling me your symptoms, it's almost like you had a very quick onset anxiety attack, and that's what we see a lot. We generalize that it's a anxiety attack or it's a cardiac event. This is one of those times where something presents like something else, but it's something, something completely different, and we can't treat it exactly how we would think in the book. For you with your tachycardia, where you initially were 160 to 180, textbook says must be SVT, must be adenosine time or cardioversion time, and that's where some people are going to pick, and it's not going to work, and we're just going to be like, we're going to scratch our head and be like, well, why is this cardiac issue not being resolved?
Right.
And that's when we got to dig a little deeper. So serotonin syndrome, real quick, there is 3 levels to it. Generally, it's mild, moderate, and severe. They're all going to involve tachycardia and hypertension, but they're going to escalate into other things. So in your mild, you have tachycardia, shivering, diaphoresis, mydriasis. For those out there, remember mydriasis is dilated, so big word. Mydriasis equals dilation. and intermittent tremors or myoclonus.
I was shaking
then,
like a leaf. I remember that.
There you go. I mean, just checking off these symptoms. And then we're going to move up into our moderate. And that's where we're going to start seeing our increase in temperature. Okay. And more hyperactivity and some mental status changes into hypervigilance and agitation. So now this is where we're crossing into that part where the doctor was saying that this usually presents with severe agitation, the bad psychological effects. Ken got lucky and got the good psychological effects. I don't want to say lucky, unlucky.
Lucky.
You know,
It's
for
lucky.
himself and for his coworkers in the end. You know, and then we're going to step up into severe, and that's where we're going to see extremely high levels of hypertension and tachycardia. Excited delirium is what we would have called it before, but now severe agitation, and they're going to present like that medically induced severe agitation. And that's probably how it's good. That's how we need to then treat it, because we need to calm them down, calm their system down, get them cooled down, get their heart rate down, get their hypertension down, all these things, and then transport to the hospital. Yeah, and like Ken said, the benzos that he was administered probably saved his life. You know, it calmed him down. It got him to a point where his body could kind of stabilize, and then they could figure things out and treat from there instead of just ramping up higher and higher. And you know, this is 2016, so 8 years ago. Our handling of severe agitation at the time was still very much developing, and we were having a lot of issues with figuring out how best to manage those patients, both out of hospital and in hospital. You know, this was like, you know, it's always been around, but it just became even more back then. And then one last thing before Ken and the docs talk anymore about the actual management, and I do have one question at the end. Some meds to look out for, SSRIs. So if you're not familiar with the names for SSRIs, look for prams, citalopram, and is citalopram. Those are Celexa and Lexapro. And then your teens. So fluoxetine, fluvoxamine, paroxetine, and sertraline. And that's the one Ken was on. Or Zoloft and Paxil and Prozac. So those are your biggest trade names there. And so if you see those, that's something to think about in your diagnostic and your assessment phase, figuring out your differentials. Look at those and be like, wait a second, like this isn't something cardiac. These meds are meant to keep someone calmer, not excited. So something's wrong. Something's going on. And then, so that's a quick recap of what serotonin syndrome will present like and some meds to look for. And Ken, what do you think, in your opinion, was what clued the medics around you into this is something different?
So I think part of that falls on me. Not that I'm like here to toot my own horn, but I know I told them repeatedly that my medications just changed and something was wrong with that. And I think that helped clue them in. Because I know I told that to the paramedic, and I know I told that to my old supervisor, and I know they communicated that. Well, I assume they communicated that to the hospital. And I think that's what it was, because if I got somebody like that, you know, not knowing what I know now, I would probably think they were on drugs. You know, I mean, that's what it looked like. It looked like I was on drugs. Which kind of brings me to a question for Dr. Brady. Especially, you know, back in 2016, now, you know, we use ketamine, we use midazolam. What would have happened had they hit me with like 5-Haldol or droperidol or something like that? Could that have worsened things, or?
So droperidol more so than Haldol. Obviously, we don't use any of the antipsychotics in serotonin syndrome, but like droperidol can actually decrease your sweating, which would actually prevent you from being able to cool yourself down from the hypothermia that you can experience with serotonin syndrome, which is why we typically lean to benzodiazepines in treating this for the agitation and the restlessness symptoms.
Okay.
Yeah.
So I don't know, Josh, do you have any other questions before I asked Dr. Brady another question? Yeah. So, Dr. Brady, what really is serotonin syndrome from like a pathophysiological standpoint?
So serotonin syndrome is a increase in serotonin that's circulating in your system, typically, like you said, associated with medications. You did list a pretty decent amount of, the SSRIs, the SNRIs that we typically look out for. One thing to kind of keep in the back of your mind is there are other medications that, even though they aren't directly related to serotonin, like how we think of, can have a serotonergic effect. So the ones that,
sorry, I was just thinking, I think I was on lithium at the time too.
okay, the ones I think of are fentanyl. Fentanyl actually can be serotonergic in nature. Cocaine reduces the reuptake of serotonin, so it acts kind of like an SSRI. And then tramadol has similar receptor patterns as serotonin. And then there's a whole bunch of other medications, like more older generations, like MAOIs or the monoamine oxidase inhibitors. Typically aren't prescribed anymore, but you'll hear on commercials, for SSRIs or whatever, saying, "Be careful, don't take with an MAOI." That's why, because it really increases the risk of serotonin syndrome. If you take these medications. So going back to the original question is, from a pathophysiology standpoint, serotonin circulating in our body at a high level and is kind of saturating these neurotransmitter receptors that increases the excitatory pathways. So serotonin has a excitatory effect kind of similar to like a norepinephrine, which is why you get like the tachycardia, you get the agitation. And then if you have too much of it, like you said, mild is that tachycardia, hypertension, kind of a little tremulous, but not really affecting the agitation and spectrum of it. If you start to go up and more advanced, you actually start to get clonus. So either inducible clonus or spontaneous clonus, which is just involuntary muscle contraction, muscle rigidity. And then that's when you start getting into the hyperthermia side of the serotonin syndrome. And one thing to keep in mind is the hyperthermia actually comes from more so the muscle rigidity. So when we're cold and we try and warm our body up, we shiver. That muscle tremoring that we do for shivering kind of increases the combustion of energy, which releases heat in our body. So if our muscles are constantly, tremoring or very stiff and rigid, we're constantly producing or using energy, constantly producing heat, which then causes our hyperthermia. So it's not so much a set point in the brain that's causing the hyperthermia. Like when we have a fever from an infection, it's more so our body's producing too much heat. And so we want to, passively cool patients down by putting, ice packs on, or, any other kind of cooling agents, wet, cool water for conduction and convection releasing of heat. Tylenol doesn't typically work with the fevers associated with serotonin because, once again, it is not a hypothalamic thalamic pathway of heat production. It's a muscle production of heat. So kind of going with that, we want to avoid restraining patients in this. And I know in the back of an ambulance, I've been there many times with a very agitated patient. It can get really tight if there's a patient who's like extremely agitated trying to attack. But we want to try to avoid restraining them because the restraining can cause worsening of that muscle straining that can lead to rhabdomyolysis. So we want to try to avoid restraining. Obviously, safety of the crew also is a very important the aspect of what we're doing. So, everything is kind of patient dependent. And then once you get to that point where the muscle rigidity is too much and your fever goes too high, then you can get comatose state. You can also get seizures. And that's when it starts to get lethal, when you get to that temperature. And so typically when patients hit a temperature of 41 degrees Celsius, which I believe is about 104. I did the math a little while ago and I forgot to look it up before we came on this talk. But 41 degrees Celsius, we typically will intubate and paralyze the patients to prevent them from continuing to produce high temperatures and try and protect them from getting to that point of where it becomes fatal.
So it sounds like if you have particularly somebody in that moderate to severe serotonin syndrome who's agitated, there's actually multiple benefits to giving, benzos as chemical restraint / treatment, essentially, right? Like there's actually multiple advantages. Is it safe and or effective to consider a drug like ketamine?
So I don't know how effective it is. I don't see why it wouldn't be safe because it acts on different pathways. It acts on NMDA receptor pathway. So I don't see why it wouldn't be safe. I don't know if there's any data out there that looks at ketamine in a severe agitation from serotonin pathway.
Okay. I'm sorry, Josh, did you have something? No? Okay. So let's say we are out on the street, running our calls, and we get a call for somebody who's agitated. And it's 3:00 in the morning in the alley. And this person is clearly agitated, hypertensive, tachycardic, tachypnic, hyperthermic, all the things that go along with extreme severe agitation. What kind of things can we look at, especially when we don't have a good historian available, to help us differentiate, serotonin syndrome versus, a chemical issue in terms of like a drug versus even like a manic episode or psychosis versus, some other cause of the similar presentation that we're all familiar with?
And I think that is a very important question to ask because, especially from the hospital side now, we rely on the history that is obtained from the field, from you guys, from the EMS side of things. So if any kind of contact clues like pill bottles, there's any kind of pill bottles lying around, any drug paraphernalia in general, like you said, typically it's related to prescription medications, but it does not mean that it cannot be associated with other kind of illicit drug use like cocaine or fentanyl use. But if you find any kind of paraphernalia around, especially like you said in an alleyway, it's going to be very difficult to ascertain whether or not this is a serotonin or a manic episode. The one thing I would say is kind of look for clonus of the eyes. If there's like movement of the eyes horizontally, almost like a nystagmus picture where it's just like spontaneous on his own, just kind of clonus picture of his eyes. Muscle rigidity also kind of points towards a serotonin type picture as opposed to like a manic episode or just any other kind of toxicology or toxidrome that could be associated with ingestion of something. So those are the ones that I would look for the most, is like that, like I said, that muscle rigidity, clonus. I know I never did reflexes when I was in the field, but I started doing reflexes more in the hospital side when I have patients who are kind of a undifferentiated ultramental status agitation, to kind of start looking for if there's any kind of producible clonus or hyperreflexibility of the joints, because those are kind of things that point me towards the direction of possibly a serotonin syndrome.
So real quick, something to ask Ken, and then also kind of you, Doc. Ken, when this happened to you, were you making sense when you talked? Do you know if you were, if your coworkers ever said that, like, hey, everything you were saying making sense, compared to other severe agitation cases where they don't quite make sense?
That is a really good question, Josh. So at first, I was coherent enough and sensible enough to communicate. I know I was able to communicate at least to the point that I got to the ambulance. But by the time I was in the hospital, I was no longer making sense. So I'm not sure where the line was exactly. But I know, like, my wife has told me that when I was in the hospital, I was just speaking nonsense. And then they shut me up with Ativan and Valium, and we had a hard reset. But but when it first started, I had, thankfully, the self-awareness to communicate what was critical in terms of my medical history and medication changes to the ambulance crew. But at some point, yes, I became incoherent and I became nonsensical. Yeah.
Okay. And that's probably as you worked up into mild, moderate, maybe even very parts of severe.
I wonder. That kind of brings up a question. I'm sorry, Josh, and I'm not trying to step on you here.
No, you're good.
But I wonder, is it? There's so many things in medicine that we say, okay, there's mild, there's moderate, and severe. Like we grade it, right? Mm-hmm. But I think in reality, like a lot of what we see, it's almost like a spectrum. right?
Oh yeah,
Like there's like
100%.
a little bit from moderate, a little bit from severe, a lot from mild. You know, I question the effectiveness of the way we grade things sometimes.
Oh, I would agree wholeheartedly with you. And Doc's nodded his head very, very, very vigorously. And I think
my rule of thumb with that is if anything's in the severe category, I call it severe because that's going to be the most pertinent of it. But yes, I agree completely that there's kind of a spectrum of disease processes that we encounter.
Yeah, it's kind of. I was talking to some EMT students the other day. They were riding along, and we were going through like just talking about stuff. And I don't know. I don't know where I got to it, but I got to anaphylaxis somehow. And I was like, look, in class they told you it's this package of symptoms for anaphylaxis, and they're like it's this, and this, and hypotension. And I'm like, look, it's anything plus hypotension. Once you hit the hypotension, you're in a shock state. That is anaphylaxis. You can just have the GI. Like I had a lady that was GI symptoms only with hypotension. I was like, oh crap, this is laying dormant, waiting to strike at the right moment. And so it's kind of like that. Like it's not always what the book says is mild, moderate, severe. You got to pull pieces from it and figure out what's going on. And it doesn't always. No one ever fits the textbook case. Rarely. Every now and then you'll see like the MIs. The MIs always stick out as like textbook cases. You get the person that just, oh wow, this is exactly how they presented it in class. But with Ken's case, I think you have a very good point with that. You float along that spectrum of symptoms, and the reason I asked this is like, and it's just convenient that you brought up the scenario, Ken, of the 3 a.m. in the alleyway, agitated patient. I'm thinking back to a patient that I don't know. There's no way of me knowing at this point. Like 2 years ago, that may have been, like a serotonin syndrome type event because he was, agitated, but he was able to talk to me and everything, but you could tell he was tachycardic and tachypnic, and there was no really reason for it. And in the end, it ended with the patient going into rhabdo and then spending a week in the hospital for rhabdo. And this was all off of a traffic stop. And involved a lot of it was on scene for like 45 minutes while they figured out what was going to go on with the patient before he became my patient. But so yeah, it's just like it's a sliding scale. Say that it's a sliding scale of symptoms.
We have a saying in medicine that if only patients read the textbook, the diagnosis would be really easy because nothing ever fits the textbook of any presentation. And so one kind of trick that, there's a diagnostic guideline for serotonin syndrome for kind of things to keep an eye out for, in the field. And obviously it might be difficult to ascertain the first important part of the diagnosis, which is a serotonergic medication has been on board or just recently changed. But then if they meet that plus any one of these following conditions is diagnostic for serotonin syndrome. So one is that spontaneous clonus that I was talking about, where their muscles just kind of contract on their own. It almost looks like that little jerking motion that they can't really quite control. An inducible clonus, which is where you actually, like push their joint and, shorten the muscle, and then it kind of starts to contract on its own. Plus agitation or diaphoresis. So either they're agitated with that inducible clonus. Ocular clonus, which like I said is kind of like a roving eye motion or like a nystagmus type picture. Plus agitation or diaphoresis. And then a tremor and hyperreflexia. So like I said, I've never checked reflexes in pre-hospital medicine. It's not even taught, so I would not expect anyone to have come into the hospital saying, "Oh, this patient has hyperreflexia." But that's one thing to kind of keep in the back of our minds in the hospital. And like I said, I had a couple patients that I was concerned for serotonin syndrome, and I had to, neurologists don't like when we use our stethoscope as a reflex hammer. But that is my go-to technique. Hopefully no neurologist is listening to this right now because they'll be very upset with me. But every once in a while, they got a reflex hammer if I'm really concerned about, want to check for hyperreflexia. I'll bring out a reflex hammer and check it. And then the last one is the serotonin medication plus hypertonia, which is just really stiff muscles, kind of muscle rigidity. They can't move. And a fever over 38 degrees Celsius or 101 or 100.4 is 38.
So I think that first point is very interesting. The history of the serotonergic medication, and you mentioned that's not always easy to get. And I think the reality is a lot of people are, even today in 2024, hesitant to say yes, I take medication like that. Um, I know, like, it was not the first thing I wanted to disclose to my coworkers when they came and picked me up. Like, it would almost, I was like, not that I don't think I thought it at the time, but, almost better that they would think I was on drugs than, taking crazy pills, right? But, um, if you want to, help yourself, you have to be honest, right? But, people aren't always going to be forthcoming with stuff like that. So it's hard to sometimes get that history, and the people around them don't always know, right? Like, I'm very open about my mental health now, but if you go back 10 years, I was not. And if something had happened to me and my wife wasn't there, you would have no idea what was wrong with me. You'd have no idea what I was taking. Like, even Moose and some of my other close friends at the time, like they had no idea. So if I like went crazy out in public, that probably assume I was on drugs.
So we have to break the stigma.
That's it, man.
Post COVID, a lot of us in the healthcare system, went on antipsychotic, antidepressant medications, anxiety medications. Now it becomes kind of a joke of like, oh, which one are you on, and kind of go around and trying to break that stigma, because especially in the recent years, like serotonin syndrome has increased because increased prescribing of these medications, because there is more of a social awareness surrounding mental health and the negative impacts of mental health. And so there is an increase in prescribing these medications. And in fact, there was a study I was reviewing for this that showed, in geriatric populations, serotonin syndrome has increased from like 1.2% occurrence in of 100,000 to like 3 or something like that, because of the increased prescribing of SSRIs and SNRIs to the geriatric population because of depression.
Yeah, it's fascinating. I mean, I really think that these problems are vastly undertreated and underdiagnosed. And I don't really blame the medical community for the most part. I think it's us as people, as individuals, who are afraid to get help for these kinds of problems, and they're not seeking out the help they need because of the stigma, because of the fear, the embarrassment, the I'm weak. I still see it on like social media pages I follow. Real men don't take these kinds of medications. Real men don't go to therapy. And it's just amazing to me, because quite frankly, if it weren't for therapy and medication, I'd be dead. Many times over. And that's no exaggeration and no joke. So I think it's really important that we do address these issues in our society. And there are still challenges, even within the medical community. Of course, we're not perfect, right? Going back to the whole bipolar disorder thing, bipolar 2 in particular, if there is, again, if that's not something that's on a spectrum between 1 and 2 and everything else, because you can mix and match things out of these different, my brain didn't read the DSM-5, right? So, but that gets misdiagnosed as depression a lot. And people throw these, and that's what happened to me. They throw these antidepressants at it. And, like what happened to me is some of them did nothing. Some of them made things a lot worse. They triggered hypomanic and manic symptoms. And some of them helped a little bit. And I was reluctant to go to a psychiatrist. So I just had my primary care doctor throwing pills at me. And for whatever reason, they never recommended that obviously I wasn't getting better, but they never recommended that I follow up with a specialist. It took my therapist, basically forcing me into it to go. And I literally went kicking and screaming and crying that I didn't want to go see a psychiatrist. But it turned out to be the best thing I ever did.
Yeah.
Hey, I had a couple questions. Well, I guess first a comment and then a question. I can't help but think that, um, you know, all of us bring biases into, the calls that we run, right? And I can't, help but imagine that if the circumstances were different, right? And say, Ken had the benefit of like being a paramedic, working as colleagues, working with colleagues that like believed him, so on and so forth, that I wonder if there's instances of that diagnosis never coming out, right? Because
Oh, I mean,
you come out and maybe they'll say, oh, it's just drugs, right? It's just some, and I know it's a sensitive topic, but I mean, certainly there's certain subpopulations where they get that it's documented that their care is quite different than others, and um, when I think about it, like how many folks are just dismissed as, oh, he's just on drugs, right? And I can't help but picture a few incidents that have become very famous that we now know those were drugs, but what if that person was experiencing some sort of illness like serotonin syndrome and we neglected it, dismissed it, maybe ran it BLS and sent them tied up and prone, and then they arrested. You know what I mean? It's just not really a question there, more so just a comment of we don't know what we don't know, and
and I
how many
mean,
people.
and that goes to all levels. It goes to all levels of healthcare, Moose. Like I vividly remember a time where, when you approached me about giving this topic of serotonin syndrome, it immediately brought a patient interaction that I had where a healthcare provider just threw this patient to the side, was trying to admit him to my service, and agitated, restrained, kind of unknown ingestion history. And I was like, this is somewhat kind of concerning. He was febrile, like temperature I think was like 39 degrees, like febrile, and I'm like, I'm actually concerned for serotonin syndrome. So I actually broke out the reflex hammer, walked over to the unit that the patient was in, checked reflexes, and he had hyperreflexia. And I was like, I went to the provider taking care of him. I was like, hey, like I'm concerned for serotonin syndrome on this. They go, well, we don't know what he took. I said, exactly. Like you don't know what he took. He could be on SSRI. He could have taken fentanyl on top of that, and that right there can be serotonin syndrome. Like you don't know what we don't know. What we don't know. You have to keep a broad differential in these patients, and like I was concerned enough, and ended up getting admitted to the ICU because of how high his temperature was, and hit a little bit of rhabdomyolysis, a little elevation in his creatine kinase, and I was like, I'm concerned enough. I think this needs to be at least investigated. Management's pretty straightforward. It's all supportive care, unless it's like really severe. Then there's an antidote that we use that has a little bit of effect. But for the most part, supportive care. But restraining him, tying him down to the bed because you don't want him getting out and running around is not the treatment.
Yeah, and certainly EMS has an opportunity to go from, because clinical inertia is certainly a thing, right? Like what we do in the pre-hospital setting certainly carries over into the emergency department and the inpatient setting. There's an opportunity, and again, not just for serotonin syndrome, but for anything, like you said, for EMS's care to influence in an impactful way what gets done at the hospital. Certainly, if we show up and we advocate for the patient, say, hey, listen, like we looked through their meds, right? We looked through their history, like we're concerned for XYZ. They're not going to hopefully not listen to that, right? Hopefully they're going to listen. Someone's ears are going to perk up, and at least we'll put a bug in someone's ear, right? So no, it really speaks to the potential impact or detriment that EMS can have, especially in these zebra cases, right? I mean, what do I mean by that? Like, when you hear who's the horses, not zebras, but this is certainly one of those things. Like, it's certainly a zebra, but it's an impactful zebra that folks should know about. And, certainly we have a colleague on the show that has experienced it. So, it certainly trumps the importance of it for me personally. I did have a clinical question. So Ken had mentioned that he had a variable heart rate of 160 to 180. Is that correct, Ken? Is that presenting? Yes. Thank you. Is that presenting as a sinus tach generally, or any other? Like, would you expect any other changes on a 3-lead or a 12-lead?
Typically, I think of sinus tach. Obviously, anything that is agitating to the heart can send it into AFib. With RVR, patients with a baseline AFib, if they are given a serotonergic medication, my rule of thumb is if a patient has a baseline persistent AFib and they get tachycardic, like in sepsis, even if they get when we would get sinus tachycardia, a persistent AFib is going to go AFib with RVR. So it's, not all AFib with RVR is pathologic, that it's just the heart doing it. Sometimes there is an underlying cause that has to be parsed out. So for the most part, though, it's sinus tachycardia. Like in the general population, it would be sinus tachycardia.
Cool, thanks.
I guess technically SVT, because technically 160 to 180 is not sinus tach at that point. It's SVT, but yeah.
That's all I had for now.
I will say, I do remember when I first put myself on the monitor, I saw a P wave. I remember looking for that.
Was it an upright P wave in lead 2? That's
Right.
all that.
Right.
All that.
Yeah. Yeah, it was quite an experience. And I think it's something that people need to be able to look out for. It's exactly like Moose said, it is not common. Like you said, Dr. Brady, you're talking about 1% of 100,000 people, it's uncommon, but I think back now, you guys brought it up, all of those patients that I had at 3:00 in the morning that I chemically restrained, physically restrained, brought to the local community hospital and just assumed they were high. I, even having been through this myself, it never occurred to me that some of those people may have had serotonin syndrome, and maybe they did. Maybe this is something that's highly underrecognized and underdiagnosed. It's not like there is a blood test that you can do a finger stick or a venipuncture and be like, hey, your serotonin's high, you have serotonin syndrome. This is a diagnosis made by clinical observation. And if you don't know to check those reflexes, and you don't know that the temperature is highly significant, because you think back to when we used to use that awful outdated term of excited delirium, we were basically taught anybody who was really hot and acting really crazy, that's what it was, and just restrain them, sedate them, and take them to the hospital. But how many of those people were dealing with the same thing I dealt with, and they just weren't as medically literate and able to articulate in a reasonable time frame to the people taking care of them what was wrong with them? I got really lucky. I recognized something was going on. I called for help and got help before it really set in. What if I had ignored that for another 5 minutes? I mean, that's how fast this went. I mean, we're talking within 30 minutes, I was standing on my own, recognizing that, I was feeling tachycardic and shaky, to, being incoherent in the hospital, getting doped up with benzos. So it progresses very quickly.
And we just to cover the bases here. Follow your protocols and your guidelines for your agency. Okay. I know the doctor said to try and hold off on physical restraints because of this is a muscle rigidity induced hyperthermia, not a hyperthalamic issue. But for your safety and the patient's safety, also consider using restraints, but use them judiciously, use them correctly. Don't be doing this hog tying, proning out, strapping down to the cot, anything like that. Use the known best practices, which are either one high and one low. That means one arm up and one arm down, or both arms to the side rails. I think in this case, probably both arms to the side rails is going to be your best case for not inducing much rigidity of the muscles by restraint. I know when they go high, it can kind of get stuck in they're in one position, but if they're down low, they can actually move them a little bit. There is a little bit of not free reign, but controlled reign of movement, and restrain chemically as needed. Okay. The patient needs to get to the hospital safely. You need to get to the hospital safely so that they can get that treatment and figure out, hey, is this serotonin or is this something else? Is this trauma induced? Is this illicit drug use induced? Whatever. But follow your local protocols and your guidelines for your agency or wherever you work and practice. So just want to put that out there. I know we say at the beginning, but just want to wrap it up there at the end too.
Yeah, and what I would add to that is this sounds like someone where if we always think about chemical restraint, physical restraint, but some folks I think consider it as like an escalation if you're like chemically sedating. But in this scenario, you may be causing harm to the patient by not chemically sedating when if they're actively working against those physical restraints, right? So of course your security comes first, but also don't be afraid to chemically sedate. That being said, I can't stress enough what Josh said. Follow your local protocols, and this is not medical advice by any means.
Yeah.
But what I would also say, or not, but additionally, I would say that's why you should be monitoring this patient, right? This patient should be on a monitor. This patient should be on waveform capnography. You should be monitoring their respiratory rate. You should be trending things, right? Not just taking snapshots in history. This is not the person that you allow your BLS provider to restrain and then you drive to the hospital. Absolutely not. Why do you think I'm saying that, right? Because I've heard it happen. And then additionally, like trending is super important, I would imagine, with these patients. So we can paint a picture for what we saw before the sedation occurred, and then during immediately during the sedation administration, and then immediately after and the transport. So so many pearls. So glad, Josh, you brought that up because that's crucial to what we do.
And I know this is just echo after echo at this point right now, but I see it time and again in QA, the line that the patient was too agitated to assess vitals. And that is one of those cases, sometimes the meds are not warranted. Sometimes the meds are just the person's not being cooperative. Like they just don't want their vitals taken. But there is the other line of that they are in an agitated state due to some exogenic or endogenic reason. And we need to control that so that we can then properly monitor them. So that's where the chemical restraints do come into play. That you're now able to get that blood pressure, you're able to get that pulse ox, get the end tidal on them, get the leads on them because they are sedated and you're able to properly monitor them. And, it's just, we should not just be chalking it up to patient is too agitated for vitals because we're not properly monitoring our patients, plain and simple. We want to know, post meds, are they still tachycardic? That's probably a good thing to know. Post meds, are they still tachypnic or whatever it is? And so do your best, exercise your best judgment in these cases. Nothing is black and white. There's no like definitive yes, this is how this is done, and there's no definitive yes, this is not how this is done. There is a lot of gray with these patient types, with these call types, and sorry for adding another layer of gray by talking about serotonin syndrome to make you think, is this agitated patient actually a serotonin patient?
I have a question for you guys. Oh, sorry, Ken, go ahead.
Oh, no, that's okay. I was just going to say, and for what it's worth, and this is highly individualized, and I can only speak for myself, but after I got those meds and then woke up the next day, I was so thankful that I got them. Like there was no malice against the hospital staff or anything like that. Like I'm really glad that they sedated me because it helped. It helped me and I wanted to be helped. And of course you're going to have patients who are going to not want help even the next day or something like that. Like some people are just ungrateful jerks. But yeah, I don't know. I don't have anything else to add to that. I'll throw it back to you, Moose.
Yeah, no, I have a question for you guys because this is something I ran, obviously not serotonin syndrome, but a similar, agitated patient. So how do you guys handle it? I'm very interested to see, Dr. Brady, how do you handle it in the hospital setting? Patients that have capacity, but are also showing signs and symptoms that are, very concerning. So I'm talking like heart rates 180, 190, diaphoretic, maybe even admitted use, right, of these agents. That's one of the biggest gray areas for me, where I know the textbook answer is contact medical direction, but like tangibly, how do you all, first Josh and Ken as paramedics, and then Dr. Brady, how do you handle that? And then I'll tell you guys how, for this specific case, I handled mine.
So you have to have a conversation. Like, you have to be comfortable talking about what's going on with the patient and what you want to do and why you want to do it. Tell them why you're concerned about their heart rate being so high, or whatever is the outlier to your vitals or to your assessment that is concerning. And tell them, hey, look, this is what I want to do. I want to help you out with this. And this is how we're going to do it. It's going to make you feel this way. It's going to sedate you. It might put you to sleep. And I'm not doing this out of any ill manner or, any ill way. I don't know how to say it but right now, but have that good, informed consent conversation. And then be like, this is why. And are you okay with me doing this? And if they say no, that's when it's like, okay, let's escalate this to, let's get a doc on the box and be like, have the doctor talk to them. It also kind of helps sometimes, and this is very situational dependent. If it's a female that's going through this, it might help to have a female provider if you have one. Talk to them about what's going on. I've never run into same race or cultural disposition being that binding thing that, I don't want to listen to you because you're white, brown, yellow, orange, purple, whatever. And I need to get someone that is of their same color or race, culture, ethnicity to talk to them about it. But that could be something to think about. And just always act in the best interest of the patient. And sometimes, unfortunately, the patient doesn't want to help themselves too much. And we have to kind of live with that. But we live with it by doing all the right things leading up to it. Not just saying, they don't want to listen to me, whatever. I'm going to get in the captain's chair and we're going to go lights and sirens to the hospital because I don't want to deal with this anymore. Do your due diligence. So, Ken?
Yeah, so this actually brought to mind a case I had slightly before I left my former employer. And I would echo a lot of what Josh just said, but the reality of the situation is I looked the patient in the eye and I explained to them there's a very real possibility that you might die if I leave here right now. I had a guy who, elderly gentleman, had fallen, hit his head, had a big old cut on his head, completely alert and oriented, reeked of alcohol, had a blood pressure of like 80 something over or whatever, a little tachycardic, didn't want to let the crew assess him at all. Eventually he acquiesced and allowed me to get some stuff on him when I got there. And I looked at him and I said, Mr. So-and-so, if you don't go to the hospital with us right now, there's a very real possibility that you might die. And he looked at me in the eye and he said, I understand that. And I hope they bury me next to my wife. And what do you say after that? Is there anything you can say after that? So I did the thing. I consulted with the hospital and they're like, well, if he has capacity, blah, blah, blah. And I'm like, yeah, he's got capacity. And I think the reality of the situation is there comes a point where patient autonomy is just the rule of the land. And if you understand that you may die because you don't go to the hospital with me right now, all I can do is tell you that. I can try to call your family and convince you and take you to the hospital you want to go to and let you sit where you want to sit and use lights and sirens or don't, or whatever little thing it is I can negotiate with. But the reality of the situation, if someone is dead set on not going, all we can do is make sure they're informed, have them sign a refusal, get a witness signature, consult with the hospital, and hope them the best.
Yeah, I'm going to preface this by saying, in America, we have the right to make the wrong decision, right? Like that is 100% allowed in the hierarchy of autonomy in healthcare. You can make whatever decision you want that you think is in your best interest, even if as healthcare professionals, we say 100% is not in your best interest. With that being said, echoing what everyone else said, have a conversation with the patient. And I will start off by saying, always try and be like a calm, de-escalating voice. A lot of the times, especially in the hospital, I can't say 100%, pre-hospital, because typically sometimes the patient calls themselves and then says, oh, I actually don't want to go. Sometimes family members try and force family members to go. But like sometimes there's an agitation component already involved in the conversation. So you always want to be a de-escalating voice. I know many healthcare providers, including myself, that are guilty of, I'm working at 24, it's 2:00 in the morning, I get this call saying this patient wants to leave, and they're 100% going to go regardless of what you say. And I go in, I'm just very, exhausted, burnt out, whatever you want to say, and just, am not my best self, which, leads the conversation down a wrong pathway of informed consent, in my opinion. So you need to, collect yourself and have a very de-escalating conversation with patients and really explain everything to them. I don't typically try and say, if you don't do this, you're going to die, because I think that is jarring to patients. And I've had patients, when I was a, younger provider, give feedback, very negatively to people, saying like, who wants to hear that? No one wants to hear that I'm going to die. And I'm like, well, I mean, it's the truth. You could easily die, but it's all about how you word it to the patient, and kind of not be so jarring or try and go for that shock effect. Like, oh my God, I need to stay. I'm going to die. So it's just having a calm, de-escalating conversation with the patient, outlining everything. Like Josh said, this is why I'm concerned. This is what I want to do. These are the side effects of what I want to do. But ultimately, if they have capacity and you deem them to have capacity, they understand their, the actions of their decision and the negative consequences of those decisions, and they're able to repeat them back to you. That's one thing I always say is, I want you to repeat back what can happen to you if you do not, accept transport, or if you leave the hospital. And with that being said, I've had patients that had capacity, left the hospital against medical advice, and then within a day they're back in the hospital. Like, that's the nature of what it is. They got sicker because, like I told them they would. They didn't want to, die. They came back to the hospital. So every once in a while that will happen. Patients have like that realization of, oh my gosh, what they said was right. But it's a matter of, very calmly explaining, this is what I'm concerned about. This is why I'm concerned about it. And going back to what Josh said about like a female provider with a female patient, I do think that there are some disparate populations in this country that do have a very valid distrust of the healthcare system, and I think that kind of expressing, something as simple as, I had a patient who didn't want to get the COVID vaccine because he thought that we were trying to poison Black patients. And I just sat down like, look, I'm concerned about you. You're overweight, you're diabetic. I'm concerned that if you get COVID, you will pass from this. And I do not want to see that for you. And then my next appointment, I saw him in the outpatient side. He was like, doc, I listened to you. I got the COVID vaccine. Something as simple as that, they just like sit down, like, look, I understand that you have distrust of this healthcare system, and I do not blame you for that. But this is why I'm concerned about it. And, in very personalized conversation about the risks with the patient.
I'm so happy you said that, because the personalized conversation is huge. Because you mentioned something about, maybe it's 2 a.m., maybe you're out in the back end of a 24, and maybe you're not all there, or maybe you're just frustrated. It's so important to, like, for lack of a better term, like, button up your shirt before you walk in, right? Make sure your shirt's tucked in, but like mentally is what I mean, right? Because your patient's going to feed off of your energy. The example that I had, and I won't, obviously can't go into too much detail, but I sat on scene for 45 minutes trying to convince this patient to go before they accepted. And am I ashamed to say that? Absolutely not. Because I was really concerned for this patient. And what ended up working was two things. And this next part's a little bit of a hot take, but I was very clear with the patient and law enforcement that I was not there with law enforcement. That did a number with my, how I looked in the eyes of the patient, because now suddenly I wasn't with law enforcement. and I made it very clear that, sir, I am not with these guys. I'm here to make sure you're okay. Now, was law enforcement happy? Absolutely not. Did I care? Absolutely not. Because I was there for the best interest of the patient. And I know that's a very hot take, but I think that's the correct take. And I will stand by that 100% of the time. Next, I ended up using a family member to convince the patient to go. And essentially, because I could tell the patient was not going to listen to me. But what ended up working was this patient's family members, actually, plural, convincing him to go. Well, let's edit that out, the him. Convincing them to go. And then that ultimately it was the best interest of the patient because the patient had various, issues going on with him. So it starts with you and your intent. Is your intent to ensure that you don't want the patient to be harmed, or is your intent to get a refusal and go back to bed? Yeah, I think that's all I have. But it's just you have to have your intention set first before you ever talk to a patient.
And going along with that first hot take that you gave, in the state that I used to run, which I believe most of us run, is, the state troopers run the helicopter service. So if you call a helicopter, the state troopers arrive, and warning the patients ahead of time, like, hey, just a heads up, they're going to have, the state trooper, patches on. They are healthcare providers. They are truly there to help you. So that way they're not having that shock effect when they show up and freak out, think that we're trying to trick them into thinking they're going to get in trouble with the law for whatever's happening. It's truly, they're there to help you. And I warned patients beforehand when I was calling aviation in to warn them, hey, just heads up, they're going to have a trooper patch on. They are there as healthcare providers. They are not there to arrest you. They're not there to do anything else other than take you to the hospital for you to get healthcare.
Definitely an important thing to bring up and address and put out there for everyone else to hear. So I think that we all wrapped up. I think that wraps up the topic for anything else anyone wants to say?
Thank you,
I got
Dr.
nothing.
Brady, for doing this.
Of
Yeah,
course.
thanks, Doc, for coming
This has
back
been
on.
on the docket for a very long time.
Yes.
And thank you again, Ken, for being so vulnerable and sharing your story about your experience with this.
Of course. Thank you.
I'm just happy we finally got to do this, Ken, because I feel like when
Yeah,
we
me
first
too.
started the podcast, this was one of the topics you had mentioned, like within the first couple of weeks of us even talking about this. So I'm happy we finally got it.
It's good that it took this long because now I'm at a point where I can really talk about it freely and openly without any reservations or embarrassment or anything like that. So I think it's a good thing that it took a few years to get this off the ground.
Well, it's happened. It's out there. And hopefully everyone that just listened got something from it. Whether it's about serotonin syndrome, whether it's about handling patients like this, or it's just about being open and transparent about one's own experiences and using it to advance the knowledge and wisdom of the other people around them, as Ken did tonight. So, thank you for listening. If you're not following us already, follow us on Alert Medic 1 on Instagram. Plenty of content coming, plenty of episodes coming out. Got a whole hopper full of stuff on the docket and also waiting to be published. So,
real quick, follow us on Spotify, please, if you don't already.
Oh, yeah. There you go.
Thanks.
Follow us on Spotify. And wherever you are, good morning, good evening, good afternoon, whatever it is. Be safe. See ya.